First, I apologize if our speakers that would like to attend at the panelists, but their names actually their names have not been mentioned here. But you're welcome to join to our panel discussion. The title of our panel discussion is AI and Dementia, clinical discussion about the challenge and problems. The panel moderator of this panel discussion is Dr. Nguyen-Vi Mohamed. She is a neuroscientist with entrepreneurial skills. She did her thesis at University of Montreal, and she was a postdoctoral fellow at McGill at the MNI. And she had many research. She has done many research in the field of Parkinson's disease, and I got a lot of funding from Parkinson's Quebec, Parkinson's Canada, and currently she teaches STEM cells technologies at University of Montreal, and she actually also co-founded a bakery that is funny, and we would come to your bakery. She recently joined MedTech Plus as an account executive to help for the maturation of innovative healthcare technologies. And is over to you, and please just start the panel discussion. Thank you.
Thank you, Ma. It's a great pleasure to be a moderator for your panel discussion today. There were like fantastic talks before, very, very interesting. So as Ma mentioned, we're gonna discuss about the challenges and promises for AI and dementia. So before jumping into the session, I would like to ask the attendee, the panelists, everybody in presential or virtual to raise their hand. There's a virtual hand at the left bottom of your screen. If you have ever known anyone affected with AD or any type of dementia. So I'll give you some time. You can raise your hand here, left bottom. I think so.
And, yes. Sorry for interrupting you, but we don't have your video, or maybe I don't have your video. I don't know. Luciana, can you see or it's just me that cannot see you?
Who can't you see?
I do see myself, so I don't know if you can see me, but I do see myself on the screen. Maybe if I make myself as a presenter. Oh, no. Okay, Gilles, do you see me at the screen?
Yeah, the problem is that once there is someone sharing the screen, we are not able to see all the people that are attending. So if there is no need to use the PowerPoint, I would highly suggest to shut it off.
Yeah, please. Yeah, because we don't need it anymore. Yeah.
Okay. And do you see now? Do you see my camera? No, still? Yeah. Some people say yes, so I guess, yeah, Kiril and Cathy say yes with the head. So
it really depends on the mode that people have chosen. Sometimes, for example, the image that will feature is only the person that is speaking. So it really depends on the way that the person decided to show the image.
Okay. Do you want me to do something specifically?
Well, I don't think so.
Okay, well, I think then we can jump into the discussion. So thank you everyone who react virtually. We can observe that many of us are somehow related to dementia, with our parents are related. So it's a huge work that everybody is doing here today, and sharing is very important for the community. So thank you. So now for the panelists, I would like to ask you to introduce yourself, especially the one who didn't speak this morning, so we can get to know you better. So maybe Cathy Malas, if you want to introduce yourself, please go ahead.
Sure. Thank you so much for this wonderful invitation. So my name is Cathy Malas. I'm a clinician from First Training, so I'm a speech-language pathologist. I've worked with children that had neurocognitive diseases, less dementia. And I always did research, clinical research, applied research in my first field and in management. I did also studies in management. And today I lead the Pole of Innovation and Artificial Intelligence in Health at SHUM, at the Executive Office, and I'm the associate to the Chief Innovation Officer, the CEO of SHUM. Nice to meet you all.
Thank you, Cathy. What about you, Kiril?
Yeah, hi everyone. Pleasure to be here. So I'm Kiril. I'm co-founder and CEO at Purple Gaze. We are a team of neuro and computer scientists who are building the AI platform for detecting neural biomarkers using eye movements. So we use computer vision and eye tracking to detect abnormal patterns in eye movements that are biomarkers of multiple brain-related disorders.
Thank you. Olga, I don't see your camera, but if you can introduce yourself as well.
I have my camera on, so you should be able to see me. Hi, my name is Olga. I'm currently a director of data science and strategic analytics at RBC, where I apply machine learning and automation for capacity planning and optimization. I've been working in the field of data science for over 10 years, and I bring a diverse data science experience from various industries, including healthcare. Thank you. Nice to meet you all.
Nice to meet you, Olga. Nouha?
Hi, everyone, and thank you for the invitation. I'm not in the field of research, so maybe I'm one off among all the huge panelists. I'm Director of Research, Development, and Quality of Services at the Federation of Alzheimer's Societies here in Quebec. So we do represent the Alzheimer's societies. So we do have 20 Alzheimer's societies in Quebec, and we are among the big family of Alzheimer's societies across Canada. So my role at the Federation is really to promote the huge work that has been done by researchers like you in the field, and also to really to support our Alzheimer's societies in the work that they do in terms of services they provide to family, to people with dementia, from information, support, respite, education program. So I'm really thrilled to be here with you today and to discuss about how artificial intelligence can really change the way we do a diagnostic for dementia, because that's obviously a huge challenge for our families. Thank you again.
Thank you, Nouha. I think Gael, Narges, and Dr. Shehroz as well, we heard you this morning during the talk, so you don't need to introduce yourself again. Did I forget anybody that I don't see on my screen? If it is the case, just please raise your hand and talk ahead. Otherwise, I'm going to ask the first question. Okay, so anybody? 1, 2, 3. Okay, let's go. First question. So I would like to ask you, what challenges do you believe the AI community face in developing AI-powered system to detect dementia and advance research in the field? So maybe Kiril, you can start to discuss about it if you have some thoughts.
Yeah, sure. So at least from the company perspective, I would like to outline two major bottlenecks. So the first challenge I would say is access to data or data sharing policies. So in some countries, especially, have very strict policies on data sharing, and despite that, they say that they want to be at the forefront of the innovation. The access to data is very restricted, and hospitals themselves also are reluctant to share data with the medtech companies. And at the same time, they are saying that they want to be at the cutting edge of science and technology. I'm sorry, I don't think that this works this way. So we really need massive data sets in order to train accurate AI models. The second bottleneck that I'm seeing is that we don't also really have mass screening of healthy individuals for brain-related disorders. So basically, we go once or twice a year to check to the dentist to check on our tooth health, but we don't really do this for our most important organ, which is our brain. And so we only come to a doctor to check on our brain health, then it's not working properly. And at this point, I'm afraid most of the time it's already too late to do something. So there are some initiatives being proposed currently. One of them is a neuroscreen from Society of Brain Mapping and Therapeutics in the US. So yeah, I think by having more relaxed data sharing policies, also combining data sets from multiple hospitals, for example, this could lead the way to the progress in this field. And secondly, we need to have some mass screening also on the national level in order to detect dementia and other brain-related conditions when it's not too late to intervene and improve patient outcomes.
Thank you, Kiril. Anybody wants to follow up on Kiril's points? Narges, maybe Cathy. Narges, yeah.
Hi. So I totally agree with a lot of these points, and I just want to add one additional maybe challenge or aspect that could be improved, which is benchmarks. So some kind of a shared task, a shared maybe commonly accessible but normally updated data set, maybe annually every few years, where different people could compare their algorithms and methods to some extent. And then we can, like apple to apple, actually start to compare models, because there are actually a lot of papers, but the field is confusing in some way. It's hard to compare things. Is my model better than yours? My data set was different than yours. So in other fields of AI, like usually these benchmarks have made a lot of difference in natural language processing and computer vision. the ImageNet, etc. So I think it would actually really revolutionize our field as well. So that was one I wanted to add.
Thank you. Yes, yes, Shehroz, go ahead.
So building on the point of Kiril, I totally understand because my primary appointment is at the hospital, so I can attest to the ethical guidelines that we have to follow, right? So, for example, the video data is a big no. I don't think under any circumstances, we can share that data, or at least the protocol that we develop. But I basically come from a computer science background, so I have a lot of empathy and for people of my field, right? And I totally understand in the absence of any active collaboration, it becomes really a bottleneck, and it's really hard to get access to the data. So one of the things that we are thinking and trying and having this discussion in our team, that can we make the sensor data, for example, available, de-identify the data, of course, but then when we wrote the ethics, we never talked about that we will share, right? So moving forward, if I have to do this study again, let's say, I would try to put this upfront in my ethics application, that part of this data, maybe not the video data, but some part of the data can be shared, right? And then accordingly, we can do the consent forms and all. The problem is now the study is completed. Some patients may have passed away, right? So who's going to go retrospectively and take the consents again to release the data and all? So it is a challenge. So I think, but we can learn these lessons and we can incorporate some of these in our newer kind of studies. In terms of collaboration, we did it successfully. We collaborated with a company, with a Canadian company, Nova Scotia. We used their devices, and they also have some access to the data, but they're not more in the data analytics side. They're more in the hardware development. So I think these kind of possibilities do exist depending upon which group is more receptive on working with collaborators. I'm very open. Our team is very open in working with industry collaborators because we don't want to reinvent the wheel. We don't want to create these sensors and devices. If something is there, sure, why not? We can use it. So I think it depends upon different groups and different factors. So this was my point.
Thank you. Yes, Olga, you would like to add something?
Yes, maybe I can also add, from generally speaking, some of those issues. I agree with Kiril, such as sharing of data are important for development, I would say, but for the deployment, other things become important as well. So there is lack of understanding, and generally speaking, how does the AI evaluate patients? From my experience working with data about real people, sometimes they see similar people to have the same issue, but the AI might output results that are different. So this kind of questions could bring lack of trust to the deployment of AI, even in a small scale deployment solutions, when it's not even a diagnostic yet, but as an augmentation of an employee that is looking at the patient and their history. I also agree with Narges that overall history and multidimensional approach to the patient is very important, because it's so hard to diagnose and there are so many different ways to approach this problem. So historic availability of historical data on a person becomes so much more important, as you can see how they can be, and from my experience also on with people with dementia, one day is not the same as another. So the day of the evaluation becomes so much more important. So historical data is also very important, and not just the prior neuroimaging or medical records, or but multiple language and speech analysis tests, and also the overall history of the patients as it relates to other things that are outside of maybe medical records, where we could deploy NLP and other analysis to study about the patient.
Thank you, Olga. So exactly linked to your point, I will like to ask a more general question. Where do you think we are positioned in terms of support for diagnosing dementia problems using AI? So I don't know, maybe Nouha, you have like some thought to share?
Yeah, thank you for putting this question to me directly. I would probably also wave in to what Dr. Korotaev mentioned about the early diagnostic. This is a huge issue, in fact. People, when they come to their family physician, they are already at a moderate to a late stage of dementia. So all what you are mentioning about data and access to data and sharing data becomes very problematic if we want to act at an early stage. There is also a lot of stigma surrounding still the disease. So people don't go to see the doctor to say it like loudly, I have memory issues, or I can feel that I have probably dementia or another form of dementia. So the stigma and the fear of a diagnostic become a huge challenge for the person to come forward and speak to their doctor about their issue. So the diagnostic becomes very problematic. I mean, from both sides, from the person point of view and from the family physician, especially that so far we are still like with a pen and paper to diagnose dementia. And AI is way far from the reality of a family physician or even from specialists. So there is here two challenges: the fact that we have to act in a very early manner, and the fact that AI can be potentially very useful for family physician, but they don't see it, or they don't use it, they don't know exactly what it is. So there is a lot of, I think, of raising awareness among the medical community to what are the purpose of AI, how they can benefit from it, and how they can use it. So because it will really have an impact on diagnostic. And we can see how people are frustrated, are also really, there's a lack of resources to help them through this journey. And I'm not speaking about the follow-up and the services. And if we only look at the diagnostic aspect of the disease, we are far away from what we should be doing. There's only few countries around the world who have a dementia strategy. So there is still a lot to do on this issue. And even though there has been a lot of education, a lot of tools, a lot of tests who are made available to family physicians, they themselves still don't provide the diagnostic. They themselves still feel that they are not properly trained, or this is just a matter of aging. So we still have a lot to do regarding the education and the awareness around dementia, because at the end of the day, it's the patient who is paying the high price. Because when we are basically far away in the journey, the resources are much less available, and the change is also inexistent for the person and the family.
Thank you. Thank you. So anybody else would like to comment on how the medical community have challenges in employing AI to detect dementia? Maybe Olga give like some clues, and Nouha share some thought as well. Narges or people who are, Gael, yeah, if you want to.
So maybe I can talk a bit about our experience on not dementia, but using electronic health records in the hospital. Because one thing that hasn't been mentioned so far is that, you know, you can provide a recommendation, but the question is, how do you put it in production? Olga somewhat mentioned it. And how do you put it in production in a way that provides value to the system, whether it's the hospital by decreasing the costs, or the patient in any other way, or the patient family? And there are so many challenges, and it's going to depend from hospital to hospital. But basically, you have a very complicated structure with many different people, with an IT system that is, at least the ones in France, a terrible mess. And now you're talking about putting in production your AI system. And so typically in France, we have electronic health records, we have millions of them, and we might want to do NLP on this. There's no way they're going to leave the hospital. It's completely unrealistic. So we might need to instantiate a modern large language model on these things. Oh, so suddenly we need a cluster of GPU inside a hospital. There's other kind of challenges I see.
Yes, Katy, you would like to add something on that?
Yeah, so I'm not a data scientist or data engineer. My expertise is in managing innovation and AI within organizations such as an academic university center. So I can answer to this question: how can we engage the medical? I would say medical. It's not only doctors, right? Nurses, healthcare professionals, to better actively participate in the developing trustworthy solutions. And I'll give a general answer, not necessarily linked to dementia. So there are few solutions of AI directly impacting patients that are in care right now, right? It's coming, but it's still not yet there. For reasons such that was mentioned earlier on, but in order to engage the healthcare workers, they need to understand what is the value creation that any kind of AI solution can bring. And then you'll ask a question later on: how can we design, implement trustworthy AI? If they are, and I'll give an element of answer, if they are actively engaged from the start with IT experts, data scientists, data engineers, patients, administrative agents, if they co-create solution from the start, from problem definition, need definition, I strongly believe that we'll be able more quickly to introduce AI solution within practice, and by raising all the other challenges of confidentiality and interoperability and reliability of the results. But I think it's essential to consider the healthcare workers, the medical community, and I will say patients too, as actors from conception, not once it's developed, not once it has been tested, from conception. And every actor will have different roles in the cycle of development. So I'll end with that: actively engage them from the start for the need identification and what is the value hypothetically estimated and then confirmed in experimentation and implementation.
Thank you, Katy. So anybody wants to add something on that? Narges, yeah, go ahead.
Somehow this on the side, I'm not sure it works for me, so I just raised my hand in the picture. So I have been at NYU Langone Medical School, and maybe I can share a little bit. It's a medical center. It has GPUs. It has intention to use technology. So maybe I can share a little bit the experience from that point of view. It takes a very long time and patience and working together to build these tools. I completely agree with Katy's comment that from beginning, these projects need to involve IT personnel, actually top-level management, because the resources that require deploying these tools into, in our case, Epic, which is the system we use, is actually quite non-trivial. So like, a computer scientist sitting in an office, it's so far away from a tool that can actually be deployed. Just even think about the data streams. Where are they coming? Which databases are, the EHR system updating on daily basis, on hourly basis? There are different databases that even have data at different resolutions. Connecting which one with which one? Where is it? Which virtual machine is it? Like all these interesting aspects. These are take time. They take resources. So they're not trivial. They require investment. They require support. But then also, I guess I'll also maybe resonate with, I think Nouha mentioned that, like in terms of education, specifically for dementia, there is a to some extent fair point that patients and doctors sometimes bring to me, and there are researcher doctors that tell me that, okay, we don't know what to do about it. Like, okay, there's a diagnosis, but what can we do? Like, there's no medication. I just, but then again, me as a outsider researcher who have studied a lot of, research, there are things to do, like these trials that are coming out. There are things to prevent somehow the onset of the disease, etc. But I think the issue is education as well, which exactly was what Nouha was saying, both for patients and also for providers. There is this stigma, but then some of these preventative metrics are not even about dementia. They're about cardiovascular issues. They're about certain things that are doable. And so, there's a lot of interesting aspects that could be improved. Yeah, my thoughts.
Absolutely. So how can we foster a research community across academia, government, the medical community, and the AI community in trustworthy AI for dementia? What would be the tools for you to go with or to use, or that you might be aware of or not aware of? Cathy, maybe because
Sure. Again, I'll give an example that's not linked to dementia because it's not my field of expertise. But let me give you an example of diabetic retinopathy. I like examples. So in 2016, it was one of our first project of AI at TRIM. So we worked with an industrial partner, one key stakeholder in the ecosystem, in validating in real clinical setting the screening of diabetic retinopathy. So right now, the ophthalmologist or the optometrist does an invasive technique to see your retinopathy, but then with the photography of the eye, you can see if there is presence or absence. So only screening, not grading, not severity grading. So we worked. So what did we do to build foster this community? So we had researchers, applied assessment and real people having expertise in real life assessment. We had clinicians, we had managers, we had people from the government, from the Ministry of Health that followed this project. So I mentioned clinician, had nurses, we had the frontline managers around the table, and a patient partner that embarked later on. Since it's a tool for clinician first, we embarked them later on. So again, from need identification, we did a very good analysis of the key stakeholders, and through the evolution of the project, so experimentation, implementation, value assessment, report generated from this value assessment, and now we are at integrating it and adopting it in real clinical care, so sustainability of the solution. We were able to do that because we worked in an open innovation ecosystem and an open innovation community where every stakeholder had its role. And in order to be able to, because we want to aim for sustainable AI, right? Trustworthy AI, but also sustainable AI. I believe that your question is essential, is that not only the research community or the healthcare or medical community is important, but also government, industry partners that work together, again, same common objective, taking a problem, for example, detecting dementia, screening for dementia, and finding the right people at the right time to work on these projects. So by doing responsible AI, security by design, confidentiality by design, equity by design. And I think we cannot do that if we don't work in a rich, open innovation ecosystem.
Yes, Olga, please go ahead.
I totally agree with everything Cathy said, and I've heard that collaboration through and engagement of different stakeholders through other comments as well. And I think one thing that brings up is the cost. So from what I've seen making a difference in the past, that's really where it starts. I've seen the collaboration can be fostered through funding of joint projects. So hospitals and the research community working together from the start on the problem and proposing to work together from the start. I think some of you might be in that environment based on the presentations that I've seen from our speakers earlier. So that's very good to see. an important is to establish communication channels where people can meet each other and establish that collaboration, because we are often baked in our environment of I'm just a research, or I am doing data science and computer science, and everybody I know does the same. And or I meet patients and I talk with them and I do the diagnosis, but I've never met computer scientists maybe in my life or maybe in a year. So establishing communication channels through events such as this one, or through communities of practice or associations is sometimes that's where people meet each other, and a lot can happen later, including the collaboration and joint projects. I think some of you in the presentation, the career progressions. So thinking about career progressions, and it works better in some countries than other. So think of a career progression from academia to the industry. Here in Canada, where I am based, it's very difficult. But in other countries, I've seen different approaches to hiring. So progressing from an academic to working in a university, and not always in a research environment, but in an actual hospital within the industry, and progressing back, or maybe moving on to government. So that career progressions bring a lot of diversity to the person's background. And one of you mentioned empathy, and that's where the communication that is needed and transparency is really developed, when the person can communicate to different stakeholders and understand their point of view, or maybe on data sharing and privacy of the patient, and then turning back and saying, but without solving these issues, we cannot move on. We cannot solve anything if we don't start talking about it, which is the case for any industry. And from the government standpoint, is really leading the way in the health technology, to having the policies and having the legal requirements. There are real legal and ethical concerns with dementia patients. Through my personal experience, I understand that. So I think having clarity from the government and from the legal community standpoint is also important. To your question, where you mentioned academia, government, and the medical community, I think for dementia specific, legal community is also the case, because it's a big impact financially, emotionally, legally to the patient when they get the diagnosis.
Absolutely. So this is exactly what we do at MedTech Plus. So this is where I work. Actually, it's a research industrial consortium. It's a non-profit organization where we put all the actors together. So the academic center, the clinician, plus the industrial. And we put money from the Ministry of Economy and Innovation to actually de-risk the project. So it's less money put by everybody at the end, but it makes a better project with everybody involved and all the expertise involved to make it happen. So this is exactly what we do there. We do it for the development of the technology, but also for its deployment. So it's really important to keep that in mind, that you have the research, but at the end, you know, to get to the patient, to be useful for the society, there has to be an impact commercially as well. So we follow the industrial partners and the researcher with the expertise all along this process, because this is a complex one. And so you need a lot of actors to help you to get through this journey. Yes, Dr. Shehroz.
Now, just a point on what Olga said. I think funding is the traditional source of kind of working and fostering these collaborations. So if you are in a Canadian kind of ecosystem, then opportunities, you know, like based on MyTex, you know, if you want to do a short-term kind of project, you know, so with I think $10,000-$15,000, you can do like a 1 unit kind of project and do some feasibility study. If you want to do a little bit larger 1-2 years project, then NSERC Alliance and other options are available. AgeWell, like there are many non-profit, like you were saying, Nguyen. AgeWell is like a pan-Canadian kind of network. And then I'm also on a review panel in Quebec, and I'm really CQDM, and I'm really surprised like the amount of money, Quebec is spending, and I wish Ontario is more more proactive on that. So it's really fascinating, those huge, like multi-million, I would say, projects where companies and academia are working together. So, like, kudos to you, Quebec. I'm so jealous, envious at the same time, but this is great. If you look at from a Canadian perspective, I think this is great. Now, in terms of, I think I may be repeating myself about the data and all that. Uh, Collaboration can happen in multiple ways. Like, it can be even in kind. It can be sharing your device. So we were actually a part of a American startup. We were a collaborator in their NIH grant. The grant was successful. We did not get any money. We only provide them consultation, So sometimes we also do things pro bono, That's okay. And we have been successful in building this collaboration. So it's just not like we have a geriatric psychiatrist on our team. We have people from, let's say, nursing professors, because I think one of you talk about, co-designing. Like, I think I heard somewhere, or maybe it's just my brain talking to me, co-creation and participatory design, because this is a very specific population, people who are designing solutions for dementia patients are themselves not having dementia, right? And a major problem is younger people are designing these technologies for older people. We do not have PhD students who are 60-year-old, maybe on a rare occasion. Most of the grad students are in 20s or 30s, right? So it is very important to get into that mindset. I don't know what my 77-year-old mother thinks anymore. I really have no idea, right? Because I'm not that age. Maybe when I'm 77, I don't know if I even live that far. But so the point is, there is this gap. Even after all this collaboration and all that thing, okay, data is there. There is this gap. Who we are creating for? What do we want to do? Are those people involved in that design? I can come up with a very funky, crazy AI, but or a complex interface, right? But if that person with severe dementia, they're just going to throw it. And I'll tell you one example. Actually, this is what happened in our first study. We bought these Empatica watches, and they're very expensive. At that time, they were around $2,000, right? We bought 3 of them, short of funding. One of them actually disappeared. Now, it's just a clunky piece of watch. You cannot sell it in a black market or get $10 out of it. I don't think. I mean, it's a great research equipment, and one of the, like, a joke, or maybe it's a reality, was that perhaps one of the patient put it in the throw it in the toilet and flush it away. That's the best hypothesis we came up with. $2,000 device just went down the drain. We had no idea where it went, right? So you need to understand your patients, spend some time with them. I think that is also important. Computer science people, we need to come out of those silos. In my postdoc, I started this research, and first few months, I can tell you, was so heavy for me. I have not seen dementia patients in my life before, right? And it was a very overwhelming experience, everybody behaving in a very different way. And I used to go there, and it took me some time to adjust in that environment. And also my level of respect for the nursing staff, the doctors, everybody, actually, I value them more now, because they are a very difficult, different type of population. So when we say collaboration, it does not just mean academic or scientific collaboration. Spend time. I always tell my students, you want to analyze the data, spend an hour, watch, observe your patients. How are they behaving? What are their specific needs, right? And these are very personalized. The way I envision this research is, because these are very different types of behaviors, depending on what you want to do in the dementia research and technology, for example. It has to go in a very personalized manner. Every person's requirement is different. It's really hard to build one fit all size kind of solution. So more involvement, I would say, in a nutshell, more involvement with your patients, with the community that you want to serve. The challenges in a nursing home long-term care setting is very different from a dementia person living in the community. And there is a sizable amount of people who are living in the community, and they have totally different requirements, right? Spend time with their caregivers. are actually running a feasibility study where we are involving the caregiver also. In fact, just my student told me this morning they put up the sensor system in their homes, and this is the first data that we are starting to get from today. So we want to know the caregiver's perspective. How are they feeling while they're living with a dementia patient? So working closely with that population is also important. And I know for data scientists, it's like, oh, I don't care, I just want to work on the data. That is not sufficient. You need to know what to like your specific solution is addressing what, right? So
yeah, that's true. And for example, when we build a proposal at MedTech Plus, we really guide everybody involved in the proposal to think about this question. Should you add an expert for not only the AI, for example, but also for the patient part? So this is question that we raised because it's truly important for the viability of the technology and for the solution. Anybody would like to add something on this question, on this thought? Yeah, okay. So I also invite you to look at the chat box, guys, because there are plenty of people who comment on what you said. And I think it's really interesting to read about their personal experience, because this is what we have here in the chat box. And now I would like to invite the attendees to ask a question that they might have. Or Mike, if you have seen some of them, you can also help me just to ask them to our panelists.
Please, excuse me, I just interrupt you. If you have any question, please raise your hand, and we actually open your microphone so you can talk and ask your question.
Yes, please go ahead, the attendees. While they're figuring out the technical aspect of that, I do have another question. There are a lot of concerns about equity, diversity, and inclusion in AI systems. So according to you, what would be the good procedure to ensure that AI for dementia is actually inclusive? What are the current challenges associated with this topic for you on a daily basis?
Maybe I'll answer on a more, again, on a managerial perspective, and I'll let, how can we translate it on the technical side? So I want to go back to what I said earlier on about the importance of co-creating, and my co-panelists mentioned it. So how can we, from need definition, include the vulnerable population? For example, people with dementia from different backgrounds, native, the community autochtone, or minority groups that suffer from dementia. How can we, in order, before answering a question through an AI solution, what are their specific needs, their specific pain points? What are the solutions that what are the pain points that we want to address? And then documenting, having, according to the question, let's say we want to better screen or diagnose or predict. How can we collect data that represents this segment of the population? And we cannot do it, I strongly believe, without them. And there are managerial techniques to do equity by design. Design thinking is a methodology, but then you have specific components that you need to apply to respect equity, diversity, and inclusion. I'll give you just one example, okay? Dismantling power. So if you're working with like community autochtone native communities, they will not, the way we ask question is a white dominant approach. How can we adapt, if we want to collect data prospectively from these populations? How can we adapt the methodology of collecting data, or if it's retrospectively analyzing data with their lens? It's not easy to dismantle this power relation in order to build this trust with them, and then maybe interpret, not maybe, surely interpret the results, for example, from a predictive learning model with them. Does it translate to your reality? How to engage with them also needs to respect the way their values, the way their beliefs, their preferences, And it's not an easy task, because we need to be in a posture of empathy and recognizing that they're in a vulnerable position. But there are techniques that allow us to really do equity by design on a co-creation perspective.
Thank you, Cathy. Yes, Gael?
Maybe I can compliment it because Cathy started by saying she was giving the non-technical perspective, so I can give the technical perspective. But I guess my technical perspective isn't that different, anyhow. You can't, even in AI, problems such as equity, fairness, they're not only technical problems. In no way are there only technical problems. We can give a few technical elements to this, but it all goes back to how you design the system. And if I think technical elements, I think we need to make sure that in our data sets, especially the validation data sets, we include all the target possible people, because if we don't, we simply cannot know whether the system is adapted to them or not. So in a sense, I'm not sure I'm giving a very different answer from Cathy.
Thank you, Gael. Any other thought that you would like to share? Any other questions that you would like to discuss all together?
I think I can add to this from the design of inclusive and ethical AI. I think for me, it's the 3 pillars. It has to be designed by a diverse team. So Shehroz talked about the age of researchers, but also the gender and other characteristics are important. Then it goes to the data. The data that we work with is often masked, and a lot of characteristics of the patients are hidden. So it's hard to know if the data is diverse. So that's one problem. Another problem is the small size of the data set reduces the ability to work to make sure diverse, inclusive results. And finally, the output AI solutions, since I'm more on the implementation side and development and implementation, it has to be, the cost has to be low to make sure that it is available to everybody and everybody has access to it. Those are 3 things on that question that I want to share.
Thank you. It's very interesting. If you look at the chat box, people are making comments on your thought and your discussion. And let's see, for example, Mary just make a comment, and she was like, "What public campaigns and cool internal challenge or even fundraising drives are happening to get young people interested in this topic?" I only learn because I volunteer in junior high school. I keep finding myself coming back to this, and I am trying to learn the technical aspect of this to be able to help with research in this field. So again, there's a lot of education to do, back to what we said previously, at many levels, and this is something to keep in mind. So thank you, everyone.
I would like to share a cool initiative, because I'm looking there. This week we start every year. We have the academia for students from 4th secondary and 5th secondaire 4 et 5, secondary 4 and secondary 5. They spend a whole week with us. They see concrete care, so they go in the operation rooms. They go in the department of epilepsy and neurology and dementia, according to their interest. And we want to diversify. We want to tell them in health, there's not only the medical profession, but there's, for example, data scientists, data architects, researchers, people working in innovation and creativity. So they spend a week to explore different talents and expertise that they could take as a career path in health. So I encourage all organizations to do that, to spend a week to welcome the secondary 4 and secondary 5 teenagers, for them to have this spark of interest, so they continue in graduate studies to have a role in healthcare. So I just wanted to share this experience.
Fantastic. Thank you, Cathy. Yeah, so more initiative like this will be better. It will be for community and the healthcare system for sure. in the future. So Ma, I think we are at the end of the panel discussion timing. If you would like to take the stage and make the follow-up.
Thank you so much for interesting panel discussion. I'd like to ask you just to have some smile and let me just take some screenshot. And I just remove my camera and yeah, maybe my